Hello everyone, my name is Dr. Mohammad Taimur and I am an internal medicine resident at the DMC Sinai Grace Hospital in Detroit, Michigan. I am here to present a case report on the workflow for removal of a dislodged AVEIR leadless pacemaker from the distal pulmonary artery. A brief introduction. The implantation of pacemakers is steadily going up. Currently, there is Micra VR from Medtronic and leadless pacemaker from Abbott AVEIR available for both atrium and ventricle. While acute perioperative dislodgement of leadless pacemakers is rare, it is still possible. We present a case of extraction and reimplantation of an AVEIR VR leadless pacemaker made by Abbott, which acutely dislodged into the distal pulmonary artery with some insight into developing workflow. We have a 75-year-old gentleman who presented with pre-syncope on EKG, had a junction rhythm of heart rate of 35 beats per minute. Additional medical history included chronic atrial fibrillation, pulmonary hypertension, congestive heart failure with left ventricular ejection fraction of 45%, and end-stage renal disease on dialysis. A single-chamber leadless pacemaker was placed in the right ventricular septum using standard technique. Leadless pacemaker was released based on the criteria of the motion of the proximal end of the pacemaker, R waves of 5 mV and pacing threshold of less than 2 V at 0.5 milliseconds. In addition, acute injury currents were classic for adequate contact with the tissue. 5 minutes after the release of this leadless pacemaker, the leadless pacemaker dislodged into the pulmonic valve. Standard Abbott retrieval tool was used. However, this further dislodged the leadless pacemaker into the distal left pulmonary artery. We used standard 0.35 mm J-tip wire as well as Wright Judkins 6 French catheter to reach the leadless pacemaker. After removing the Judkins catheter to locate the proper area available around the device, we advanced the tri-leaflet snare tubing only to the distal pulmonary artery to do a venogram to appropriately localize the leadless pacemaker. After that, the tri-leaflet snare was advanced via the external tubing of the snare. The snare reached the leadless pacemaker uneventfully. The torque tool used was extremely helpful to get the screw of the leadless pacemaker stuck into the snare. The leadless pacemaker was removed into the original leadless pacemaker implant sheath. The second glide wire was advanced next to the pacemaker and the sheath was removed with the pacemaker in it, while the glide wire was in the superior vena cava. The advantage of this technique was that we could reimplant a second pacemaker through the same extra site. The leadless pacemaker was removed uneventfully from the sheath. New leadless pacemaker was loaded onto the delivery equipment and advanced it into the right ventricular septum and again screwed it in. Good capturing pacing thresholds were found and the sheath was removed. The other tools we used were steerable sheath, VisiVico, Biosense sensor and Swan-Ganz catheter to get the wire into the RVUT, but we did not find them very useful. So, to our knowledge, this case is among the first few cases of intraoperative AVEIR VR ventricular leadless pacemaker dislodgement to the distal left pulmonary artery. Workflows with easily available instruments are necessary for risk management, particularly smaller hospitals where interventional radiology tools may not be available. For removing leadless pacemaker from pulmonary arteries, we propose a kit which includes a tri-leaflet snare, 180 cm long J wire and 6 French Wright Judkins catheter be available to the operator in case of rare dislodgement of leadless pacemaker. In conclusion, AVEIR leadless pacemaker from Abbott can be removed using simple tools from distal pulmonary artery dislodgement. Our proposal simplifies the workflow using common tools including the Wright Judkins coronary catheter and tri-leaflet snare with a standard long wire. Please note that the total time including removal of dislodged pacemaker and reimplant of the pacemaker took less than 2 hours and 15 minutes. Thank you.